Well, good evening. It's really nice to see a lot of familiar faces. I won't say patients, but familiar faces. So we're going to be talking about muscle-invasive and metastatic bladder cancer. And I'd have to say that, especially for metastatic bladder cancer, we're really in a new era of immunotherapy, and even beyond immunotherapy, these new agents called drug conjugates that really will change how we look at bladder cancer, metastatic bladder cancer. So although I'm presenting to you what we know of now, I can imagine that in even 2 years, we might even see something completely different. But let's go back a little bit and talk about bladder cancer. These are statistics that you probably already are familiar with. The average age of diagnosis is in the late 60s. For reasons that we're not 100% completely aware of, their male to female incidence is about 2 to 1. About 5% of all Canadian males have had bladder cancer, and that's an astonishing number. And correspondingly, 12,000 new cases of bladder cancer in 2019. The good news in all this is that over 90% of men with bladder cancer will actually die of other causes, which means that I think that as a whole, we do a real good job in managing bladder cancer in terms of detection, in terms of management, surgical management, as well as chemotherapy. But obviously our goal is to make that 100%. And how will we do this? And this is one of my daughter's books, one of her favorite books. This is how we do it. So we're going to be talking about muscle-invasive bladder cancer. I was told that I can't include any gory, bloody videos, so this is going to be very short. That's scary. We're going to talk about the current treatments for metastatic bladder cancer and immunotherapy. I can tell you that immunotherapy is a question that almost every single patient of mine with advanced bladder cancer will ask me about, as well as some future research. So muscle-invasive bladder cancer is completely opposite what Dr. Black was saying. This is when it gets into the muscle. Once it gets into the muscle, the chance that it can metastasize increases significantly, and as such, we have to introduce aggressive treatments. We cannot treat this by just scraping out the tumor or giving different chemotherapies or immunotherapies in the bladder. We have to either remove it, that's called a radical cystectomy, or we can try to preserve it by giving patients both chemotherapy and radiation. This is called chemoradiation. The gold standard, at least right now, is radical cystectomy, but without a doubt, there are certain patients who will do well with chemoradiation. And again, talk to your local health specialist to determine which one is best for you. But how do we maximize cure with surgery? And this is the big thing. If a vast majority of patients with muscle-invasive bladder cancer are getting surgery, how do we maximize cure? One way, which is easy for me to say, but can be difficult for patients, is to give chemotherapy. So this is a very famous biophysicist by the name of Dr. Rosenberg, and he invented this drug called cisplatin, and cisplatin probably is one of the greatest ever chemotherapies, greatest ever medicines ever invented, has saved millions of patients. And interestingly, he was a biophysicist, but he was more of an engineer than anything. And he found that in his experiments, bacteria would grow 300 times faster in his area of study. This led to further study, which led to this chemotherapy called cisplatin. And the only reason I bring this up is that it's these neat little discoveries that we need to rely on that will then provide us as very significant cures. And this is what we do in research. We find little tiny differences, and from that expand into bigger treatments. But long story short, chemotherapy, in other words, cisplatin, is the basis of treatments around surgery. Very often we will recommend to give chemotherapy prior to this radical cystectomy, removal of the bladder. And many reasons why. I think the biggest reason is that we want to kill any microscopic cells that could have escaped. We want to make the tumor smaller so that when we get at it surgically, we can do a better job of removing it completely. And obviously, we want something that will improve patients' lives. We want an agent that has been proven to improve survival. And I'm just going to show, my next slide will show you that. But the disadvantage of this, unfortunately, is that it can delay surgery. There are side effects of chemotherapy. And the biggest question that you need to ask your chemotherapist, your medical oncologist, or your surgeon, are other benefits worth the side effects or the risks? And although the graph of the results of the clinical studies, the top line, that solid line, are patients who receive the chemotherapy with surgery, and the bottom line are those that not. There's two things here. The first thing is that we can improve how long you live, and number two is that you can see here, not every patient is going to do well after surgery, meaning that we don't see 100% survival long term. So which means that we have to do everything we can to improve outcomes. And again, I think that our outcomes are probably a little bit better than what's shown here. But the bottom line is that chemotherapy can improve outcomes. It's up to you as a patient to see whether or not it's something that you want to take. And as well, there are obviously certain indications in which patients just can't take it, whether their kidney function isn't good enough or they have other issues. Well, what about giving chemotherapy after surgery? Indeed, it's more enticing that we can then identify those patients with aggressive disease, give chemotherapy for only those individuals rather than giving chemotherapy for everyone. But unfortunately, the study results aren't there to show a true advantage. We can see in some of these studies here, this is a compilation of studies put on a graph, and you can see that there's a benefit of giving chemotherapy after surgery. But unfortunately, the results aren't conclusive because most of these studies ended too early. And as such, there's insufficient evidence on which to reliably base these treatment decisions, meaning that medical oncologists, so physicians who give chemotherapy, are a little bit more reluctant to give chemotherapy after surgery than before. The bottom line is chemotherapy is important. It's not for everyone, and it's something to talk to your surgeon and your medical oncologist prior to having your bladder removed. Well, what are some ways then we can actually improve outcomes of the surgery? I think there's a lot of evidence, a lot of data out there to show that you need a good surgeon. You need a good surgeon who has a lot of volume, a surgeon who has a lot of good training. You need a hospital that has a good setup and a hospital that has a good team. And one of the important components of a good setup is something called ERAS. And ERAS just stands for something called Enhanced Recovery After Surgery. It's a newer concept. It's being rolled out across British Columbia. And I'm happy to say that in Canada, Vancouver was one of the lead sites, one of the first sites to actually do this. Now, what is ERAS? ERAS is a system by which we make small little changes before surgery, during surgery, and after surgery so that we have big, big gains, big benefits of surgery. Now, it was developed by this colorectal surgeon by the name of Dr. Kellett. It was originally for bowel surgery, but now it's being used for bladder cancer surgery. You can see here it's a compilation of multiple different changes grouped together, and so that every single patient goes through all of this very systematically and appropriately so that they have the maximal care and no one is missed in terms of any kind of preoperative counseling or intraoperative management. I know it's confusing, but suffice it to say, it involves multiple different steps. It involves a lot of preoperative counseling. It involves seeing dietitians. It involves seeing nurses preoperatively, and it involves seeing all of these members postoperatively, and even being contacted at home to see how you're doing. Now, we did a small little study, Dr. Black and I, in which we randomized some patients to receive this type of system versus what we used to do beforehand. This was in 2014, and as you can see here, the different components are massive. We don't have time to go through all of them. Suffice it to say, it involved multiple different things. And these included things such as preoperative counseling, preoperative medical optimization, and small other things such as giving special types of wipes and a nutritional encouragement prior to surgery. What we've learned, though, from the study is that we need a significant amount of preoperative counseling, which is why when men and women go for surgery, they spend a long day talking about what to do before surgery. And this involves things like dietary issues, what to do after surgery, et cetera. So there's a lot of counseling. And I think for me, it's the counseling that I thought was valuable for patients. We also do a lot of things intraoperatively, and again, I'm not going to go through all of this. What we're trying to do is optimize every single step of the surgery, from when you're put to sleep to what happens during surgery and what happens after surgery, to try to maximize your outcome. We want you to do well after surgery. We want you to be healthy after surgery and have good quality of life. And the results seem to show, again, this is a small study, but the results seem to show that those patients with ARAS went home earlier, they had bowel recover better, and they needed less help in terms of eating. And so the bottom line is, this is this program called ERAS is in Vancouver. We use it in every single patient who undergoes radical cystectomy. And I think it's an important component to optimizing patient care. It involves things like having special booklets. And this patient booklet called ERAS Radical Cystectomy is this huge booklet. And I think a lot of my patients are quite intimidated by it. But again, it's a very easy read. And I tell them that they should really go through it page by page and write notes and ask me any questions if they do have any questions regarding it. So they get this well before surgery. Well, let's move on to now metastatic bladder cancer. Now, unfortunately, metastatic bladder cancer is still not curable in everyone. It involves the spread of bladder cancer to other organs, most commonly noted here, the lymph nodes, the lung, the liver, the bone, and the kidneys. And it's usually the lymph nodes is where we see the cancer. When it's metastatic, right now in 2019, your first treatment is going to be based by giving you cisplatin, that chemotherapy that I was talking to you that was discovered by Dr. Rosenberg. And it's going to be combined with another chemotherapy called Adjuvant. You could also give it in a very different type of formulation called MVAC, or you can give it with a special type of cisplatin called carboplatin that is a little bit less toxic on your kidneys. If it does come back, we don't give you another round of chemotherapy because technically you're considered resistant. And if it does come back or doesn't respond, then you can get immunotherapy. And this is immunotherapy that you get in your veins, not in your bladder, because you don't have a bladder anymore usually. And if you can't tolerate immunotherapy, or you recur or don't respond to immunotherapy, then you can receive another type of chemotherapy. Immunotherapy is interesting because these are agents that weren't around when I was a medical student. They weren't even around when I was a resident, just to tell you how old I am. But these are agents that are going to revolutionize and have revolutionized how we treat patients. And right now we're using these agents very late as second line, so after chemotherapy, but they're being rolled out earlier and earlier. And I can imagine that there'll be a time at which we can give immunotherapy even before surgery or after surgery. And there are so many different types of immunotherapies. This is why it's so exciting in that we're testing different agents to try to stimulate the T cell to kill cancers, that we're really in a golden era. The problem is we don't know which is the best one, and we don't know which concoction, so combination of immunotherapy with other agents, is the best approach. In summary, immunotherapy means stimulating your own immune system to kill cancer cells. So this is a really neat slide. The top circle sphere is a cancer cell. The bottom is your immune cell, your T cell. These are fighter cells. And you can see how if we stimulate these cancer cells, or stimulate the immune system, we can cause it to attach to the cancer cell and then kill it. And that's why it's so exciting, is that we're not giving you an agent that's going to kill all cells. We're trying to stimulate your own immune system to very specifically find and target those cancers. However, right now, as I mentioned to you before, it's currently a second line. We only give it after chemotherapy failure, so those that recur after chemotherapy. But there's now been some research to show that maybe it's important in first line. So we have new data that was just released a month ago to look at this. So there was an immunotherapy called atezolizumab plus chemotherapy. This is gemcitabine and cisplatin versus chemotherapy alone as first line. And as you can see here, that top blue line is the combination arm, and that red line is just chemotherapy alone arm. And you can see here that these patients who received the immunotherapy did better. However, although we can see that it prevents the disease from progressing, we're still a little bit early and we don't know if it actually improves survival. And so as such, it's not going to be approved yet, but I can imagine as time goes on, we'll show that it does improve survival, and this will very likely be an option for patients as first line in the near future. Another interesting trial that was just released was called the Biscay trial. This is a trial that I've been waiting for, and it's like an exciting trial because it is even more specific, meaning that we analyze a patient's tumor, we study what type of abnormalities it has, and then identify those gene mutations, and then use that information to then choose which drug to give. And it sounds exciting, right? If you have this certain mutation that we think the drug is going to kill, then we can give that drug. If that person has a different mutation, we can use that drug. And as you can see here, we have 3 different groups with a lot of prevalence, meaning that these are the mutations that are found a lot in these patients. So, in summary, you get a tumor, you analyze it, you identify which mutation you have, and then you get your drug. Very exciting. The unfortunate news is that it didn't work as planned, meaning that I don't think we truly understand how a lot of these drugs work. That being said, this tells us that we can actually do it. We can actually use your information that we get from gene testing and then find a drug and test it. These numbers, however, response rates, so these are number of patients that actually had reduction in their tumors, is relatively small, but you have to realize that these are patients with advanced cancers, with a lot of disease, and maybe it'd be better to use this type of system earlier. And secondly, there's one group here that did very well, a 40% response using this system. So again, I think that this will be the future, and I can imagine that in 10 years, and I'm not over-exaggerating, I think in 10 years, all of us will have our tumors tested, and then it'll tell us which drug to give. And it won't just be everyone get the same drug, cisplatin. The future, however, may rely on more testing, and I just wanted to show you one concept, and this is interesting because this is the actual concept that was funded by Bladder Cancer Canada by a grant a few years ago. So wouldn't it be interesting for us to try to test your tumor in the lab before we actually give it to you? And that will avoid whether or not you get a drug that doesn't work, and also avoid you getting a drug with a lot of side effects. So what we've been doing in the lab is growing tumors in a three-dimensional flat platform. So this is normal bladder. We remove all of the cells from the bladder using a special type of technique, and then from there we put cancer cells. So we can actually grow cancers in a tube. And unlike just growing on a plastic plate, which has been done traditionally, we're trying to grow these tumors as it grows in you. We then can use an agent and test it within the lab before we test it in you. Now, we're still very early, but with Bladder Cancer Canada's help, we've been able to develop a system already. We're ready to then now grow actual human tissues, and we've been doing so in the last few months. And we eventually hope in the next year to start testing treatments before patients are given drugs to see whether or not we can actually prove that this system works. But I think that this kind of system where we test patients' cancers in the lab before we give it to the patient is going to be crucial to avoid unnecessary toxicity. And as you can see here, this is just another way we look at it. This is a normal bladder. We remove all of the cells, and then we put cancer cells, and we can see cancer cells all along here growing inside what used to be a bladder. So in summary, I think there's a lot of hope for bladder cancer. I think vast majority of patients with bladder cancer that are diagnosed are going to be treated very well. Vast majority won't die of bladder cancer, but there's still about 10% that will, and we need to move that to 0. And in order to do so, I think things such as immunotherapy, combination therapies, and even drugs I didn't even mention today just because of lack of time, there's going to be a lot of new and exciting trials. I hope that we all get involved in clinical trials, because without doing so, we won't know and won't be able to identify which drug is going to be the best. but I think within 10 years, we're going to see a different way of looking at bladder cancer, especially advanced bladder cancer. The future, though, I think will involve more study of the tumor prior to treatment, and whether that's a test, a genetic test, or whether that's actually testing in the lab, we'll see, and maybe a combination of both. But I think the future is very exciting. Thank you.